Hi, my name is Ben Daniels from the University of New South Wales, and I'm going to talk to you about our study looking at the use of hydrochlorothiazide, lip cancer, and malignant melanoma. These are my disclosures. So, hydrochlorothiazide is a thiazide diuretic used as first-line treatment for hypertension. It's one of the most prescribed medicines in Australia and the world more broadly. And in Australia, around 900,000 people were dispensed hydrochlorothiazide in 2018, to give you an idea of how widely it's used. However, in the past few years, studies from Denmark, the UK, and the United States have found that hydrochlorothiazide use was associated with increased risks of developing squamous cell carcinoma of the lip and malignant melanoma. And following on from those studies, medicines regulatory agencies in Europe, the UK, New Zealand, and Canada all issued warnings around hydrochlorothiazide. And Australia's medicines regulator, the Therapeutic Goods Administration, also became interested in this issue. They reached out to our team, and we're all aware down here in Australia that we have the highest skin cancer rates in the world. So we were interested in what was happening here as well. Um, so we decided to investigate using a linked data collection we have from the Australian Department of Veterans Affairs that includes dispensed medicines, the New South Wales Cancer Registry, hospitalization data, as well as information about each DVA client in the data. The observation period of the data is from 2004 to 2015, though the cancer registry goes back to 1972. We focused on DVA gold card holders, which are clients with the highest benefit level in the DVA's reimbursement scheme. And this means that all of their medicine costs are reimbursed and therefore recorded in the data. We focused on gold card holders residing in New South Wales, which is Australia's most populous state, and they had to reside in New South Wales for at least 4 years prior to the cancer diagnosis. We excluded those with evidence of organ transplant, immunosuppressant use, HIV, AIDS, or a cancer history. And we also restricted participants to those who are 65 years and older, and that's because DVA clients in general are a much older cohort, and the majority of them are already over 65. And we use the start of their gold card benefits or the start of our data series as the study entry date. We used a nested case control design with risk set sampling to match cases with lip cancer or malignant melanoma with up to 20 controls based on sex and age at study entry. And we compared hydrochlorothiazide use prior to index, excluding the 12 months immediately prior to allow for an induction period. We looked at use in two ways, ever use of hydrochlorothiazide as well as cumulative use of hydrochlorothiazide. And we considered those dispensed 25,000 milligrams or more as our high use group. And that's equivalent to around 3 years of treatment. And then we used conditional logistic regression to calculate odds ratios adjusted for the use of other photosensitizing agents, treatment with other medicines thought to have potential anti-cancer properties such as NSAIDs, aspirins, and statins, comorbidities as ascertained via the Charlson Comorbidity Index. And we also attempted to account for ambient UV exposure based on latitude of residence at study entry point. And then to further control for potential confounding by indication, we repeated the main analyses for other diuretics and antihypertensives with similar indications to hydrochlorothiazide, including furosemide, ACE inhibitors, AT2 antagonists, and calcium channel blockers. The results, we had 45 lip cancer cases and 659 malignant melanoma cases. Similar median ages, though a larger proportion of melanoma cases and controls were male. Among lip cancer cases, 40% used hydrochlorothiazide compared with 21% of controls, and 13% of cases had high use compared to just 3% of controls. For malignant melanoma cases, 24% had ever used hydrochlorothiazide compared with 20% of controls, while 5 and 3% of cases and controls, respectively, were high users. And these figures resulted in an odds ratio of 2.6 for ever use and 4.7 for high use for lip cancer, and an odds ratio of 1.2 for ever use and high use for malignant melanoma. So we found elevated risks for lip cancer and malignant melanoma associated with hydrochlorothiazide use and a possible dose-response relationship for squamous cell carcinoma of the lip. And our results were very much in line with those reported from recent studies, where those studies reported odds ratios ranging from 2.1 to 2.9 for lip cancer and 1.2, 1.3 for melanoma. And there wasn't time to include it in this presentation, but we also looked at the association with different histological subtypes of melanoma and found associations with superficial spreading melanoma and lentigo melanoma. And we also thought our study was a great example of how the pharmacoepi community can address important medicine safety regulatory issues and have a direct impact. When the TGA reached out to us, we then reached out to Professor Pottegard in Denmark, who had led the recent Danish studies. He was very happy to collaborate with us, and that was a big help for our study. And as a result of his work in our study, the TGA recently issued a safety advisory for hydrochlorothiazide in August. And our study just got a lot of coverage in the Australian press, so hopefully these findings are getting out into practice. And we're planning a future study using a different data source with more people under 65 to see what's happening there in Australia, and hopefully more international collaborations. Our study does have a number of strengths and limitations. DVA clients are older, but they are representative of the wider Australian population in similar age groups. And while our participants were older, they were very resilient. They had no previous cancer diagnoses and very few comorbidities, but we still observed the risk. Our dispensing data began in 2004, so we obviously could not observe hydrochlorothiazide use prior to then. We did not have any data for skin type or ethnic background, and this may be an important confounding factor. There was another recent study in the Taiwanese population that found no associations between hydrochlorothiazide use and these cancers. And finally, we did not have data on smoking status, which is an important confounder for lip cancer. But the recent UK study did have these data and found that it did not impact the association between hydrochlorothiazide use and either cancer. So in conclusion, the photosensitizing properties of hydrochlorothiazide may promote squamous cell carcinomas and possibly melanoma in sun-susceptible tissue. These are the first findings from the Australian population, which is already at an increased risk of developing these cancers. And doctors treating patients with hydrochlorothiazide may want to provide more skin cancer prevention advice and potentially heighten skin cancer surveillance for these patients. So thanks for watching my presentation. I'd like to thank the DVA for supplying the data and thank my great co-authors listed there. And please see our paper, which was published in August as well. Thank you.